want to really make sure that especially people who don't have medical background understand the heart and its processes really well, so that, you know, so I'm going to spend a little time on background, okay, because I want you to understand it. So here's, you know, some learning objectives for what I want. And so basically this is going to be a list for you of what I want. I want you to know primary hypertension. Obviously, I want you primary hypertension. I want you to describe how you take care of hypertension. I want you to know lifestyle modifications. I want you to know nutritional recommendations for hypertension. I want you to know the nursing management of the patient with primary hypertension, if they're in a hypertensive crisis. And I want you, and this is going to be where you're going to spend a lot of your time, is on the antihypertensives, because those are going to be meds that you're going to be dealing with forever. And so I'm going to ask you a lot of questions on antihypertensives. So that's kind of a list for you about what I want. So when we say blood pressure, so this is background. I'm not going to test you on this, but I want you to get it in your head. So you can sit back and relax and just watch the YouTube. And actually, I am recording this for YouTube, so it will be there. But factors influencing blood pressure. What is blood pressure?
Force exerted against the arterial walls.
Right. It's the force against the arterial walls. So why do we see it as a number over a number?
Pressure when the heart beats, and then there's a pressure when the heart relaxes.
Correct. Perfect. So the systolic blood pressure, the top number, is the pressure on these walls when the heart beats. So when the heart pushes blood into these vessels, it fills, right? That's the pressure of the vessel at its most high, basically. Then what happens is the blood kind of flows through here and the pressure decreases while the heart's at rest. And that is the lowest pressure that this vessel is under. So that's your systolic and your diastolic. That's why it's systolic, means when the heart's beating, that's your highest pressure that vessel sees, and the diastolic is the lowest pressure that vessel sees. So that vessel needs to relax as well. If it's constantly under pressure, imagine a garden hose that you have kinked. What's going to happen in that garden hose? The pressure's going to build and build and build and build and build, and what would happen to that pressure if it kept building?
Explode.
It would explode. So it needs to build and then release and then build and then release, and that way the vessel walls stay intact. But that's what that's reading, is basically the force of pressure. So when you don't have a lot of blood flow, do you have a lot of pressure on your vessel walls? When you don't have a lot of blood, let's say you lost a lot of blood. Do you have a lot of pressure against your vessel walls?
No.
Nothing. So that's why you have a low blood pressure when you don't have a lot of blood volume. When you are volume overloaded and you have edema everywhere and you've got so much volume you can't deal with, is there a lot of pressure on those vessel walls?
Yes.
Yes. So sometimes it's heart controlled, sometimes it's volume controlled. All of those things are a factor in your blood pressure. So the strength of your heart, so you have a strong heart pushing really hard, you have a weak heart that's not pushing very well, and also your volume. So there's two things. So if you have a strong heart that pushes really hard, but you don't have a lot of blood flow, you still aren't going to have a great blood pressure. And if you have a weak heart that has a lot of volume to deal with, you still may not have a good blood pressure. So there's a lot of ifs and ands and buts on this. Don't worry about the word systemic vascular resistance, but that's another fancy word for blood pressure. So what the vessels do when they want a certain pressure, they know what pressure they like. And they will constrict and dilate to relieve or get pressure in them. So they don't have a lot of blood flow. Let's say you went out hiking and you dehydrated yourself and your blood volume is diminished. What are your vessels going to do? They're going to constrict because they want that certain pressure against their walls. They want pressure, they just don't want too much. They want that pressure of like 100 when the heart beats and 60 when it doesn't. That's like a great pressure for them. That's what they're looking for. And when it starts rising a little bit more and the pressure starts building, so then you drink 8 Gatorades and you start fluid volume filling yourself, and now it is filling back up again. What's happening as you're putting more fluid in here? It's going to start dilating, because now when you put more fluid in there, it starts getting tight. So it starts dilating out to try and get its pressure. So vessels will dilate and constrict to try and manage that pressure. So, basically vasoconstriction is another word for a constricted artery, and vasodilation another word for dilated artery. What's really, really interesting is, what do you think this diastolic blood pressure is? So at rest, when the blood's finished pumping through it, is this a high pressure or a low pressure?
Low.
That's a low pressure. A dilated vessel has a very low diastolic blood pressure. And is this a high pressure, low? So the blood's pumped through? High. So if you look at your systolic blood pressure, that's when the heart's beating. But it's the diastolic blood pressure is really the measure of how big your vessels are and how much volume you have. So if you go to clinical and look at your patient's blood pressure, people with long-standing high blood pressure, what are their diastolic, the bottom numbers?
90 or...
Yeah.
They're higher than 90, right? Because this vessel lives in a tight state. It lives constricted. And so there's always a high pressure in it. When a patient is very sick, they've lost a lot of blood volume, or they are very, very ill with a disease or whatever, and you have a low blood pressure, your diastolic could be as low as 30, which is very, very low. You have a very dilated vessel. So that diastolic blood pressure, that bottom blood pressure, is a very good measure of how open or clamped down your arteries are. So what's our normal blood pressure?
120.
120 over 80. Okay, let's just say that's where the vessels want to be. 120 over 80, that's where they want to live. They will dilate and constrict, but there are other things that happen that will mess up our vessels and make them less plastic, make them less able to do that. So that's just a little idea. The systolic pressure, love it, it's great. That's where the heart's beating. But the diastolic blood pressure, why is that so important to us?
Sets your heart at rest.
This is what the heart has to pump against. The diastolic blood pressure is the least amount of pressure in these arteries, right? Least amount of pressure. So if you have a low diastolic, what does the heart have to do to fill this? Pump hard to fill this. This is what it wants to pump against, a regular vessel. How does it feel pumping against this? That takes a lot of work. So if you are constantly constricted with that high diastolic blood pressure, that heart has to work really hard and pump against a lot of resistance. So to get blood to that, it has to pump really hard. So after a long amount of time of a high diastolic blood pressure, your heart gets tired of pushing against that resistance. So that's why we watch the diastolic blood pressure with hypertension. The systolic is important, because that's the heart's already beaten it out. We're worried about what we're doing to our heart long term, pushing against resistance for a long time. So we'll keep working through it and talking about it, and you will not leave blood pressure behind. It's going to be your mainstay. You're going to love your blood pressure. So we know that the vessels can constrict and dilate to get themselves their ideal pressure. There are also some other things that send signals to the vessels to maybe push it along to a certain blood pressure. So we have these things that are in our aortic arch and in our carotid arteries. They're called baroreceptors. Again, not testable. I could be like, what's a baroreceptor? But baroreceptors sense pressure. All right, they're little pressure sensors. And if they don't feel a certain amount of pressure on them, they send out emergency signals. So these emergency signals are flight, fight, and rest and digest. So if you have no blood pressure, so let's just say you went out hiking and dehydrated yourself, and all of a sudden you have less blood pressure. You're starting to feel a little dizzy, a little woozy. What do you think is going to happen to your body?
The baroreceptors send
Well, they're going to send out the sympathetic one. They're going to be like, there's something wrong here. My brain is not getting what it needs. The carotid ones are like, hello, I'm here to supply this brain. My brain is not getting what it needs. Send help. So what does help look like? And then if it's getting too much pressure, it's like there's too much going on. We need to shut things down for a little bit. Sends out parasympathetic. The baroreceptors are in control of your sympathetic and parasympathetic systems. This is what happens when you do not have enough blood pressure. They will send out fight or flight, which is adrenaline or epinephrine. Okay? So you may not feel it like, ooh, but when you are losing your, or you don't have enough blood pressure, you don't have enough blood volume, this will happen. They'll send out things to alpha and beta receptors. This is our first system involved in managing our blood pressure. There are a lot of systems that manage our blood pressure. This is the first one. I do want you to know that the sympathetic nervous system, and you will see this when we talk about antihypertensives, the sympathetic nervous system controls alpha receptors, beta receptors. The alpha receptors are in your vessel, and when this message goes out to your vessels, it causes vasoconstriction. So stimulating these receptors causes vasoconstriction. Blocking these receptors would cause what? Decrease vasodilation or decreased blood pressure. So stimulating a beta receptor in the heart is going to increase your heart rate and increase your heart squeeze. Okay? And stimulating beta 2 receptors is going to dilate your lung vessels or your lung bronchioles. Why do you think that happens? So your body doesn't have time to process what's going on. All it knows is it's got a signal. It's got a signal to stimulate all these things because you are needing to run away, you're scared, you're frightened. That jolt you feel when you get frightened is a burst of adrenaline, and it has hit all of these receptors. It's the most noticeable feeling, but when it hits these receptors, guess what your heart rate does? It pounds up, your heart starts pounding, and you actually start taking in more oxygen because your body has gotten scared and it wants more energy to get away from this situation. This is the primal, basic instinct. So as soon as you start losing blood pressure, these baroreceptors send that out as well. Maybe not quite as a jolt form, but your heart rate does go up, your heart beats harder, and you get a little bit of dilation when this is stimulated. So when you have a low blood pressure, the system will get stimulated. That's a good thing, right? Because the more the heart beats, the more it fills the vessel and will help with the vasoconstriction. The heart's beating harder. What's going to happen to the rest of your body? It's going to get blood. Okay? It's going to get what it needs. And then the baroreceptors will shut up. And then everything kind of resets. But for that time that they don't have blood volume, things are happening to help compensate. You can see that this is great when it works perfectly. When it doesn't work perfectly, we have problems. So the sympathetic nervous system, alpha and beta receptors, in the heart, in the lungs, and on the vessels. Okay, good. This is just another picture of it, same thing. So alpha receptors are on the vessel, they cause vasoconstriction. Beta receptors are on the heart. You can kind of see, you've probably heard about beta blockers, huh? Ah, now you know why I'm telling you all this stuff. Beta receptors are in the heart and increase heart rate and contractility. Beta 2 receptors are on the vessel, the bronchioles, and help dilate the bronchioles. So they will increase heart rate and dilate your lung bronchioles so you get more oxygen. That sounds great, right? Parasympathetic, but you'll get tired, right? You're working a little bit harder, so you get tired after a while. So after a while, we need our kickback system to say, all right, you can chill out now. We're good, and everything can come back down. So there's a nice little balance system. And this vagus nerve will cause the heart rate to go down, increase blood flow back to the intestines, and relax everything. So when you are in flight fight, do you think you're worrying about digesting your food? No. we're going to shunt blood away. It actually shuts down your gastric, there's a little bit of blood flow down there, but your blood gets shunted away from your gastric system to provide blood to your head. And this is an amazing system, our body. So it will, when the sympathetic system is busy, then the gut's not really doing a whole lot. And then there needs to be a signal like, okay, things are good, things are status quo. So when there's starting to be consistent pressure, those baroreceptors will be like, it's all good, everything can rest down. They send out signals, the heart rate comes down, and fluid stuff goes back to your gut, and you can resume your normal function. So there is a balance there. That's our first system. What's it called? Sympathetic, parasympathetic, okay? That is our first system involving our blood pressure. Our second system involving our blood pressure, and again, I'm not going to test you on this, but this will really help you understand your blood pressure medicines and help you understand when we have problems with these systems, why we have problems with our blood pressure. The second system, and you're like, I don't want to learn that slide. I don't blame you. But guess what? You're going to see it again in block 3. Sorry. But all you need to know from this system is that there is a renin, angiotensin, aldosterone system that also controls our blood pressure. So that first system, sympathetic, parasympathetic, worked with nerves, right? Nerve signals going to receptors. This is actually controlled by the kidney. So the renin, angiotensin, aldosterone system is controlled by the kidney and has some other little things involved in it. But basically, the kidney senses low blood pressure and sends out signals as well. So you can have both systems acting for you. This system, the basic of this system is that it causes vasoconstriction as well on a different receptor. This angiotensin 2 at the very end of it causes vasoconstriction. So if I'm going to pull anything out of this slide, it's going to be two things. Angiotensin 2 causes vasoconstriction, and at the very end of this, aldosterone goes back to the kidney and causes sodium and water retention. So if you are low on your blood pressure, you want vasoconstriction, what else do you want? You have a low blood pressure, you don't have enough fluid volume. You want more fluid. So we send a message to the kidneys, hey, hold on to some fluid. And hold on to some sodium, because sodium follows water around. So whenever you're holding on to water, you're probably holding on to sodium too. So it will hold on to sodium, and sodium will pull water back in. And you hang on to sodium and water, and you have a increased blood pressure. And then as soon as you have an increased blood pressure, everything can rest again. So that's the renin, angiotensin, aldosterone system. You only need to worry about the fact that angiotensin is a vasoconstrictor and aldosterone causes sodium and water retention. You can see, this might look familiar to you. Have you heard of angiotensin or ACE inhibitors? Bing, 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 there it is. That's where it works, is in this system. So what I'm going to do is I'm introducing you to these systems, and then we'll show you that each blood pressure class goes with these systems and works in there. So we have the sympathetic, parasympathetic system. We have the renin, angiotensin, aldosterone system. Okay, the RAS system. Those are, and then this is just more about that. Angiotensin 2 is a vasoconstrictor. Aldosterone will increase your blood pressure by increasing water and sodium. So those are our two systems that we are looking at. All I need you to know is that those systems exist and what they do so that you will understand your blood pressure meds. So now we're going to talk about when our blood pressure is too high. Probably because those systems don't work properly. Because if they worked properly, our blood pressure wouldn't be this high. But you probably have seen the definition. We want 120 to 180. We let things slide a little bit between 120 and 140, between 80 and 90. But once we start getting consistently above 140, above 190, we are considered hypertensive. So here are your stages. Yes, this is a slide you need to know. I want you to know the two stages. And I also need you to know that when you are in, normal's 120 to over 80, but when you are in pre-hypertension, that is a stage. It's a stage that you need to monitor and do some things, but you're probably not going to be medicated in this stage, but you are going to need to do some things in this stage. When you are in these stages, they probably start doing some medical interventions here. Stage 1 and stage 2. I do need you to know the difference. Stage 1 is either or. You don't have to have both. Either or puts you in that stage. So if you have a blood pressure of 180 over 80, what stage are you in? You're in stage 2. But you're like, well, my diastolic's okay, but your systolic's not. So either or. So if you have a blood pressure of 130 over 98, what stage are you in? Stage 1. So it's either or. So if your systolic's perfectly fine, but your diastolic's high, you're still whichever one's worse gets you categorized. Okay? Yes.
I guess general question, as you get older, even if you're like healthy, you eat healthy, you exercise consistently, will your blood pressure still go up?
It may. It depends on how your vessels lose their elasticity as they get older. So they're not able to, your blood pressure actually, if you're perfectly healthy, probably stops losing its elasticity and stays a little bit dilated. But people as they age get plaques and the vessels get narrower and they end up being high. There's a whole lot of different reasons. But all you need to know is that either or will get you in this stage. The worst number classifies you. Okay. So what if you had 150 over 105? Stage 2. The worst number classifies you. So 150 would get you into stage 1, but 105 gets you into stage 2. Okay? Do people stay in one stage? No, they fluctuate back and forth. You can be in stage 2 and then do some things, go to stage 1, they fluctuate back and forth, but it's consistent readings, 3 readings to get you classified, medically diagnosed as being in a certain stage. Has to be 3 consistent readings. Me going to the doctor and being freaked out or scared or anxious and I have a high stage 1 reading, I'm not going to get a diagnosis of stage 1 hypertension. I have to have 3 consecutive readings in that stage. But the highest number will classify you. Okay.
Question.
Yes.
So we learned that like normal is 120 over 80, but on this chart, if you have 120 over 80, you're technically pre-hypertensive.
Well, that's because that's a nice easy number to remember. Is anyone going to classify you as pre-hypertensive at 120 over 80? No. It's just a number where they can cut off. For this slide is what I'm going to go through for any test questions. But realistically, it should probably be 121 over 81 to 89. But really, I'm not going to ask you 120 over 80 is what stage.
That would be so funny.
That would be really mean. But it could, no one's going to call you pre-hypertensive at 120 over 80. Now, if you're sitting 120 over 80 and then 124 over 82, and then, if you're kind of bordering that, they might call you pre-hypertensive. It depends on what else is going on with you, really.
Didn't they also lower the normal range as like the last year or two?
I'm not sure. This is what's in your book. If they've lowered it, then we need to wait for the books to catch up. What's that?
A new textbook.
If you get a new textbook, you'll have new values. But right now, these are the values that we're going to go with. And I myself would not put you on a borderline number. Okay? For if I'm going to ask you a question. Because, oh my Lord. I don't want to do this to you people. I want you to understand this well enough to take care of patients, not to nitpick on little things like that. If you catch me on something like that, please let me know. But yeah, no, I mean, if you were 120 over 80 and a runner and an athlete, I wouldn't worry about you. If you're 120 over 80 and 80 pounds overweight, you know what? If your next one's this high, we're going to do something about it. So it kind of is a whole picture. There's never one number that's going to define you, right? It's always a whole picture. But that is a baseline, and that's what's on your book, so I'm going to go with that one. Primary hypertension just means we don't know why. It's just there. We haven't figured out why. So that just means elevated blood pressure. We don't know why. There's no reason that we can see that your blood pressure should be this high. Do you think it has symptoms?
No.
We have no idea what's going on. We didn't even know it was high till we accidentally took a blood pressure. So we don't know why, and it usually doesn't have any symptoms. Secondary hypertension is elevated blood pressure because of something. So maybe you're stressed out. Maybe you are taking a medicine that increases your blood pressure. We know why you're hypertensive. Don't worry too much about primary and secondary, but you may see the words primary and secondary. I certainly wouldn't ask you, does this person have primary or secondary hypertension? They have hypertension. But secondary hypertension is just because we know what's causing it. We know, and we have to deal with it. There are meds we give people that cause hypertension, and we're like, okay, well, we have to deal with that. Secondary cause. This slide you will get to know. This will be a good slide. This is not only in the hypertension slide, it's in the coronary artery disease slide and the peripheral vascular disease slide. So it's like a threefer. This slide goes everywhere. And I will ask you questions on this. These are things that you can change to fix hypertension. These are risk factors for hypertension. They are found in people with hypertension. There are modifiable and unmodifiable. People will argue now about the gender one being modifiable. Because, hey, you can change that. You can give yourself steroids. You can give yourself hormones. You can change that. But really, it's not easily modifiable. You can't change your age. No matter how much I wish I could change my age, I can't change my age. Gender, okay, yeah, someone did say, like, well, you can change your gender. I'm like, that takes years if you can do it well at all. So, okay, we're going to just call it unmodifiable. New textbook, new rules, maybe that'll change. But right now, gender is an unmodifiable risk factor. Family history, you can't change your family no matter how much you want to, and you can't change your ethnicity no matter how much you may want to. You can't change those, so we just have to deal with them. Modifiable are things you can do to change some things about your life to reduce risk factors. If you have 4 unmodifiable risk factors, this is probably going to become a priority you need to get rid of. If you have 6 risk factors, 4 of them are modifiable, 2 of them are unmodifiable, then, you can do more. If you have 4 unmodifiable risk factors, you're probably destined for high blood pressure. So just know which ones are modifiable and unmodifiable. The treatment for hypertension is to get it under control. If we get it under control, we don't have problems with it. We want it under control. Something happens somewhere along the line to one of our systems that things are going out of control. We need to get it back under control. So why do you think these modifiable ones increase your risk for hypertension? What does tobacco use do? It causes vasoconstriction. Tobacco is a vasoconstrictor. So if you use it for a long time, your vessels will get vasoconstricted. What is alcohol? Someone's like, that's a vasodilator. Why does alcohol mess with your blood pressure? It messes with your liver. It messes with your kidneys. It messes with all your organs, and you cause minimal organ damage, which messes with the systems that regulate our blood pressure. It dulls sensory, so we don't work with our sympathetic, parasympathetic sensation, and nerve transmissions don't go as well. And it will mess with your kidney, and that renin-angiotensin system doesn't work as well. So yes, even though alcohol is a vasodilator itself to the vessels, what it's doing to your nerve transmission and what it's doing to your kidneys on a microscopic basis is going to affect your blood pressure. So alcohol is a risk factor. Why is diabetes a risk factor? It affects microvessels, and it causes damage to microvessels, specifically in the kidney. So diabetes messes with the kidneys, and the kidneys mess with your blood pressure. So diabetes is usually part of hypertension because of the kidney issues going on. Why do lipids increase your risk?
Atherosclerosis.
Because they create plaques. The more lipids and fats you have, the more plaques you have. The more plaques you have lining your vessels, the less blood flow you can get through, so the vessel pressure is higher. Not because the vessel is constricted or dilated, but it's full of junk. so whatever pressure is running through it is higher. So this increases your blood pressure as well. Why does sodium increase your blood pressure? More fluid retention. Water follows sodium around. So if you have a lot of sodium in your bloodstream, where is there going to be water? In your bloodstream. You're going to have increased fluid volume in your bloodstream. So excess dietary sodium makes more fluid retention and causes a higher blood pressure. Why does obesity do it?
Well, it's like a whole lecture on its own.
So what's like a good basic reason that obesity would be a risk factor for hypertension? It's just stress on the heart. Okay, the heart gets weaker, doesn't pump as well. The vessels start constricting because the heart's not pumping as well. That constant vessel constriction causes hypertension. So obesity just basically is the strain on the heart. You also have a lot of blood vessels. The more body mass you have, the more blood vessels you have, meaning the heart has to pump into more vessels. It just creates a strain on the system. Sedentary lifestyle. Why is that a risk factor?
Stress on the heart again.
Weak heart. If you're sedentary, you're not very cardiac strong. Your heart is weaker. And so it's harder to pump around all that stuff. They generally kind of tend to go together. And I feel that I'm good. I'm right in there. I understand. But sedentary lifestyle and obesity kind of go together. And really the weak heart has trouble pumping very well to supply the body. And then the body sends out signals. I need vasoconstriction. And then there becomes consistent vasoconstriction. Stress. That's easy. Stress is a crisis situation, sends out signals for vasoconstriction. All right? Flight, fight is one kind of stress. Nursing school is an entirely another kind of stress. We have long-term stress response as well, which we go into in block 3. Our long-term stress response will increase our fluid volume and increase our blood pressure. So this is a long-term response. Basically, we have long-term stress will cause consistent vasoconstriction and fluid retention. And socioeconomic status, well, that's stress. If you can't afford your meds, a lot of this goes into you can't get what you need to take care of your body. So it's stress, but it's also something that we have. Now, people will argue that's not really modifiable. Okay, but we can help them get things and help them modify that. So socioeconomic status is usually having to do with I don't have insurance, I don't have enough resources to get what I want, I can't get back to the doctor, I can't get a car to get to the doctor's appointments. There's a lot of issues that go on that basically it boils down to stress, but it's things that we can help out with. So those are why they're modifiable. Unmodifiable we can't change anything about. As you get older, you're at higher risk. As if you're men, you're at higher risk. Sorry. Family history, if you have a family history, you're at higher risk. You can't, if you have a genetic predisposition for fatty blood vessels, atherosclerosis, you just have that genetic disposition. And unfortunately, ethnicity, there are races that are more predisposed to high blood pressure. What are they? African American, Native American. Asian is usually lower blood pressures, not higher blood pressures. I could probably come up with there's probably a list in the book. But unfortunately, those are the two major populations that we're going to see that have a higher risk. So if you have so if you are an elderly African American male, you've got 3 right there stacked up against you. And then what if you have a family history? Now that's 4. And then you're elderly, so you're sedentary. Maybe you're on Medicare without a lot of family in the area. Risk factors start to build up. And you become kind of, okay, they're going to end up with hypertension. So this person might do well with being taught something earlier in their stages, in their pre-stages. So we want to control the blood pressure. The first step in controlling blood pressure is to do lifestyle modifications. They're not going to go right to meds. So you come in, you got 3 consecutive readings, you're stage 1 hypertensive. Do you get meds right away? No, they're going to be that. They're going to look at your whole system, your whole life, figure out where your risk factors are, and they're going to say, you should probably change a few things. And we all know the response to that for most people. It's like, I feel fine, I don't care, you're not taking away my stakes or anything, I'm going to do what I'm going to do. So then we will move on to drug therapy. And there are different levels of drug therapy. This is not in order. It depends on your risk factors. It depends on what's going on. My husband has, unfortunately, family history. He's a male. He's got really, really, really high lipids. He's got a really, really high family history. And he said, I'm not doing any of these damn lifestyle modifications. I love him. So he said, no, none of these. So they put him on lipid-lowering medications and said, if this doesn't work, then you're headed to blood pressure medicines. Luckily, he doesn't have diabetes on top of it. But so if you have diabetes, but no atherosclerosis or no high lipids, then maybe your first step is going to be glucose control. So there's a lot of different ifs, ands, or buts. It's going to depend on your patient. Okay, everything's patient dependent. But meds are next after lifestyle modifications. And this is just more about lifestyle modifications. So I will let you kind of read through this. I'm not going to read slides to you. But this is, of course, recommendations. If we could all do this, nobody would have high blood pressure. But we can't. This is hard. So you can read through these lifestyle modifications because your job as a nurse will be to help patients do these lifestyle modifications. This is probably an important slide. They should have their saturated fat intake low. All right. Low saturated fat, low sodium. Not completely low, just start to lower it. Okay? As you have other problems going on, you end up with higher sodium restrictions. 2,400 to 3,000 milligrams a day sounds pretty big, considering that some sodium-restricted diets are 1,200 or less. So this is not a DASH diet or your to stop hypertension diet is not the lowest sodium restriction you can go. There are more sodium restrictions you can go. But this is a good place to start. Say, if we don't get control of your blood pressure, you're going to end up on a higher sodium-restricted diet. So why don't you start trying to maintain your sodium level? Try for the rest of the day or the rest of the week to maintain this sodium level. It's very hard. Yes?
This might be, it depends, but how long does usually a diet take to then you see the effects of eating anything?
Yeah, I don't know. I'm not a nutritionist, so I wouldn't know, but probably months.
Oh, wow.
Probably months. Now, if you start dropping your sodium, you may stop fluid retaining right away. But especially the fats and atherosclerosis, basically you're going to stop creating new plaques, but to break down and remove old plaques would take months to years. But sodium intake low. So what you would tell your patient who are pre-hypertensive, this is really a good idea for anybody pre-hypertensive, are your lifestyle modifications, your DASH diet. You try it if you're not already on a sodium-restricted diet. Try to go less than 3,000 a day. We can't usually go less than 3,000 a meal in this world. You go to McDonald's and add up your food, go to In-N-Out, Sonic, they're ridiculous. You're at that a meal. So asking people to just start thinking about it and being aware of their sodium in their diet might be a good first step for someone pre-hypertensive. But the DASH diet is not really a treatment diet. It's kind of more of a, hey, there's something growing here. Maybe you should start looking at it rather than just doing whatever. So keep your saturated fats low, keep your sodium intake low, and try to get more vitamins and minerals. It's just a healthy diet. Okay? Everyone should be on the DASH diet. It's hard. So this is kind of just nutritional recommendations. Again, did you have nutrition as a prerequisite or a co-requisite?
Yeah.
Somewhere a long time ago.
Depends on where.
Basically healthy diet. I would like you to remember that they should have low saturated fat and lower sodium, okay, as a DASH diet. And here is the difference between saturated and unsaturated fats. So we would want to limit these and say if you've got to have some fats in your diet, you've got to have some fats in your diet, but they should be from the unsaturated fat category, not the saturated fat category. So if you have someone who's not hypertensive or pre-hypertensive, we can introduce this. If they are in stage 1 or stage 2, they should be doing this at a minimum, if you're in stage 1 or stage 2. I like nursing diagnoses because they kind of help pull things together. So what are our symptoms of hypertension, primary hypertension? There aren't really any symptoms to know, but under signs and symptoms for primary hypertension, you could put your modifiable and unmodifiable risk factors, okay? What are your biggest problems with hypertension? What are your worst case scenarios if hypertension doesn't get controlled? Heart. Heart is our first problem. Heart is our first problem. And so if I could reorder these, which I might do as we go along, and then upload new slides. How about that? Yeah. If I could reorder these, I would put the risk for decreased cardiac perfusion at the top, not because it's the most common, but because it's the worst case scenario. The fact that if we have high blood pressure for a long amount of time, that will start to wear on the heart. That's why we want this under control. And then risk for ineffective and cerebral renal. These are my worst case scenarios. So if you're doing SOAPy cards, this is what I ask for. Ugh. This is what I kind of ask for on the SOAPy cards when I say, what's your primary concern, your worst case scenario? If we don't get this under control, these things can happen. That's what we're worried about. Yeah.
I have a question in prioritizing things like this. Where is a good place to find it?
There isn't a good place to find it. So what I'm going to tell you for that, and I didn't realize until yesterday in block 3 when we were talking, we were doing some Kahoot questions, and I banged my head on the thing because I'm like, you're not getting it. And then I realized we were miscommunicating. So when we say priority intervention, so pull away from the slide for a minute. When we're asking, when you're going to NCLEX test questions, or when you're in our test questions, and we say, what is your priority intervention? That would mean if you could do one thing of those 4 things, one thing, and leave the room, what would do the most good? So a priority intervention isn't the best thing to do from your textbook or the number 1 thing. It's you have 4 choices. Of those 4 choices, which one's the best? And that's what they're asking for when you have priority intervention. And they say here are what nursing intervention is most appropriate. Then it's which one goes with that disease. So when we go through these questions, we'll talk about our terminology that we're trying to get something out of you. We want to know that you know the most important thing to do from those 4 choices, not from all of your choices. We're giving you 4 choices. You don't get to pick any other choices. I know you would rather have the one that's not listed, but we're giving you 4 choices. Of those 4 choices, if you had to pick one and leave the room, which one would be the best one? That's what we're kind of talking about. So when we prioritize them, this will help you, I think, when you see a question where it would say monitor EKG. None of them are anything that you studied for. They're not on your list. But say your patient has primary intervention, what would be your priority intervention? And it has all kinds of random things. We'll do some questions and we'll point this out. But when we say priority intervention, it's usually, you could think to yourself, okay, of these 4, if I could do one and then leave, which one would have the most impact? And that's usually what we're looking for. And then there's all the ones with select all and apply. That's where you look at those and say, is this one appropriate? So you look at the question, you're like, what's this question asking me? And then you take each answer and say, true, false, does it go with what they're asking me? And then if it's true, you mark it. If it's false, you don't mark it. So we'll go through a couple of them and try it. There is no good place to find a ranking of what to do first, because it depends on your patient. Block 3 and 4, they hate me, because I'm like, what does your patient look like? I don't know. Is your patient 300 pounds, short of breath, and in stage 1 hypertension? Or do you have someone who is 180 pounds and 6'2" and in primary hypertension? We would resort. There is no black and white answer, and that's why we give you so much like information during the questions, like, oh, well, your patient has this and this and this and this, so that you can start sorting. But the worst thing, and the thing that we usually do when we're monitoring patients, when your patient comes to you with hypertension, I want you to think, how far into this are you? How long have you been into this? Are we close to this? To prioritize them in your mind. If you have 3 patients with the same blood pressure, you're going to prioritize the one that has these things further advanced. These are the worst case scenarios. If they're further down that road towards decreased cardiac perfusion, decreased cerebral renal perfusion, they have kidney failure, they've got hypertension, they've got stuff. They're more priority than someone who maybe just is anxious about it because their doctor told them they had it. This just helps you prioritize. They're not testable. I don't say what's your priority, nursing diagnosis, because I don't think we're supposed to test on nursing diagnoses. It's just a tool. We will keep using them. Okay. So what was the number one thing? So when we went back to the slide, if I could do your interventions for hypertension, here they are. Here are your interventions. The first ones are going to be lifestyle modifications. The second ones are going to be meds. And then you're going to have med cards for all your meds. So I'm not going to ask you to pick a med for your patient because you're not a nurse practitioner, you're not a doctor. I need you to be able to explain these meds to your patient. I need you to be able to give them to them safely. I don't need you to pick them for them. That's not your job. So what I'm going to ask you to do is, if I'd say your priority intervention for a athletic young man that's coming in with his second episode of hypertension, you identify him as stage 1 hypertension, what would be your primary thing? If I gave you these 4 as a choice, lifestyle modifications, antihypertensive, lipid lowering, and glucose control. What if I gave you all 4 of those? Lifestyle. The guy doesn't have, I'll probably give you like a list of what his, he doesn't have any risk factors, but he, he's 140 pounds, he's 50 years old, and he's in stage 1 hypertension, and he's sedentary. Maybe he sits at an office desk all day. So your interventions would be lifestyle modifications. You're not going to go primarily to, let's get you on some meds, or let's teach you about your meds, because he shouldn't be on them. He should be primarily lifestyle modifying first. So that's does that help a little bit? I feel like I can't answer your questions 100%. What I'm going to do is give you a break. And hopefully when we tie this together at the end with a Kahoot, we'll be able to talk more about questioning. After break, we're going to talk about all the different drugs. So basically, lifestyle modifications comes first, unless they are pretty severe and the doc decides they want meds. And then now we're going to talk about the meds and how to deliver them safely to people and what we need to know about the meds. Because meds is the next step up in blood pressure management. So take a little break. So diuretics is on its own. There are classes. This is what I want you to know. Now, I know somebody was telling me that Dr. Anderson has a list of a whole bunch of different meds on your lab, your cardiac meds on your lab, right?
Shake your head yes.
Yes. So, all these meds are on the slides. I expect you to know classes of meds so that you can identify. My patient's on metoprolol. That's a beta blocker. Hey, look, you already know it. You already studied. Or my patient's on captopril, which is a... Look at you guys. You already studied. You're done. No, but that's what I want you to be able to do, is to identify the med, then put it to its class, and then know from that class what all the interventions for the med are. I don't need you to study 20 different meds. I want you to study these classes. So 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 meds. And maybe not even so much the 9th med, because that one you're not really going to see much of. So the first 8 meds are going to be what I want. Now, to make things a little bit easier for you and to talk a little bit about how these are done, this is one class of meds, or one system of meds. This is one system of meds. This is its own system of meds. And these, we're going to just cross it out for right now. So diuretics work on their own to do what? Get rid of fluid. That's what they do. They get rid of fluid. What do these alpha and beta blockers, what system do you think these work in? This is the sympathetic, parasympathetic. So it's SNS and PNO. You can call it whatever. The nerve system, okay? Those work in the nerve system. Calcium channel blockers you see are actually direct vasodilators, okay? They will actually directly work on the vessels. So these right here work on the vessels directly. And then these ACE, ARBs, and aldosterone receptor blockers, what system do you think those work in? That RAS system, the renin angiotensin aldosterone system. Oh, let me just move that away from the words there. I need to get rid of that trial code. So when they pick meds, you don't pick meds, they will usually start choosing something from the class that they think is the problem. It's really easy to start people on diuretics. If your problem is fluid overloaded, you get a diuretic and it takes care of it, wham, bam, done. Yay. So the first med they usually start people on doesn't have a whole lot of side effects other than losing electrolytes. Diuretics are really easy to give people, probably people's first choices, and doctors' first choices, or nurse practitioners' first choices. Diuretics are the most common and usually the first line, and I say usually. But diuretics are one class. Then you will move on to wherever they want to hit next. So the moral of the story is you are usually on, when you see people on 3-4 blood pressure meds, they're on one from each class. They try to hit it at a bunch of different levels. Okay? So they'll start diuretics. Then maybe they'll start a beta blocker. And maybe that works, maybe that doesn't, maybe they don't like the side effects. And then they'll try a calcium channel blocker. And then they don't like that, or they don't like the side effects, they'll try something in the RAS system. The moral of the story is you shouldn't be on 2 meds in the RAS system. If one's not working, the other one's not going to work either. So you will see people, and go to your clinical. And when you look at their blood pressure meds, you'll see someone on a calcium channel blocker, a beta blocker, an ACE inhibitor, and a diuretic. That person's on 4 antihypertensive meds. You can pretty much guarantee that their hypertension's really bad, hasn't been well controlled, and what are you going to be worrying about? That heart. That heart's probably been working for a while, and they've been piling up meds. Yes? Oh, okay. No worries. So if they're on a beta blocker, they won't be on another beta blocker. Most patients aren't on 2 beta blockers. That's overkill. They'll be on a beta blocker. So when you're looking at your patients' histories, and you're looking at their blood pressure meds, all of a sudden you'll see, oh, they're trying to hit this hypertension at all 4 spots. They're hitting the RAS system, they're hitting the nerve system, they're hitting the vessels directly, and they're hitting the fluid overload. They're going at it at all sides. Or maybe they're being well controlled on a diuretic and a calcium channel blocker. Maybe they decided to hit it with those 2. Those are the meds that are controlling that blood pressure. There is no right, wrong answer, but your patient should be, if they're on multiple meds, different classes of meds, so that we can hit it from different angles, but that we're not overkilling one system, okay? So no 2 calcium channel blockers, no 2, if you're getting on multiple meds, they should be from one of each system, okay? So that's kind of what I want you to take away, and take a look at that as you go look at your patients. So let's move on. Move on. Okay, I don't want to go. So for all antihypertensive medicines, all of them, I don't care what system it works on, what class it is, if you are on an antihypertensive med, I want you to do these things for your patient. I want you to keep an eye on them for orthostatic hypertension. What is that? What is orthostatic hypotension?
Standing up.
Standing up and your blood pressure drops. That is a sign that your vessels are not constricting well and trying to compensate for that. It also is checking their blood pressure. All blood pressure meds, you should check their blood pressure. So if you recognize blood pressure med, one of your things that you had better do during your clinical is make sure you at least look at their blood pressure and see where it is and evaluate it. If they get up out of bed and they are orthostatic, that may be something we need to address. Maybe that blood pressure med is too good. Maybe it's dropping their blood pressure too much. Maybe that's not the right med for them. Maybe something needs to be done, but I want you to assess for it. Okay? I want you to look at their blood pressure, and I want you to assess for orthostatic hypotension. You don't need to do the physical, okay, I'm going to lay you down, and then I'm going to sit you up. But if your patient sits up and they're like, whoo, a little woozy, I want you to do the measurement. Okay? I want you to know that it's there. I know that it is a side effect of a lot of blood pressure meds is to drop your blood pressure when you sit up. Some patients, they know it's there. They have to just get up slowly. Because what we're doing to these patients is affecting their system, that when you stand up, what do you think happens when you stand up? When you are laying down and then you stand up, where does your blood go? Boom, to your feet. So what happens, what does your body do to stop that? It vasoconstricts so that you can keep blood up in your head against gravity. So if we do something to stop vasoconstriction, what is going to happen to them? They may get orthostatic. It may mean you need to intervene. It may mean you just need to teach them, hey, just slowly get up. Maybe don't jump up and start hopping into the shower. You're going to be a little woozy for a little bit because it's going to take your body a long time to do that vasoconstriction because we're blocking it. We're giving you something to tell you to not do it, but you need to do it. So assess for orthostatic hypotension. All meds, don't care what class. Daily weights. All meds, don't care what class. Of course, it goes without saying for diuretics. But people are like, oh, they're on a beta blocker. Why do I want to weigh them? Why do you want to weigh a patient who's on a beta blocker? Any ideas? Because they have hypertension. I want to see what their fluid status is. All right? They have hypertension. We have a problem that they're being treated for. I want you to make sure their fluid status is okay. They can measure if something is getting worse. Fluid retention is a great measure, and daily weights are a great measure of something happening. You're retaining more fluid. Something's going wrong. Maybe you're not retaining enough sodium. Maybe you are retaining sodium. Maybe you're losing weight on your aldosterone. Just keep an eye on it, okay? All blood pressure meds, as soon as you have hypertension, start looking at their weights. It's a great early indicator that something is going on, that they're starting to retain fluid. And that's a big sign that something is going wrong. So keep an eye on your daily weights. Of course, you're going to watch their blood pressure, and you're going to watch their heart rate. Do all meds affect the heart rate? Not directly. Not directly. The beta blockers will. The calcium channel blockers a little bit. Do your ACE inhibitors affect your heart rate?
They do not.
Do the RAS system, do they affect your heart? Was the heart anywhere in that system? No, they shouldn't. Now, they may affect your heart because they're changing your blood pressure and your heart can pound better or whatever. But just keep an eye on it. But know that the meds that work in those beta blocker families are going to affect your heart rate. They're very important to watch the heart rate. But always look at your blood pressure and heart rate on any patient that has hypertension and on hypertensive meds because there's something wrong already. You're looking to make sure it's not getting worse. And they all need patient education. Of course, every drug they're on, you're going to educate them on the drug that they're on. But every patient on any antihypertensive med, no matter what they are, should have frequent blood pressure checks and lab work. Okay, because all these meds, no matter what class they are going to mess with something in your body. And so they need to see a doctor, and they need to be followed. It's not something you just get a med and you go in once a year. It really shouldn't be. They should be seeing their doctor a couple of times a year, if not more. So this is something that the patient needs to have frequent blood pressure checks, even if they just go to Walgreens and run their blood pressure. They should probably be, if you're on a blood pressure med, when they're in the hospital, you're checking them 4 or 5 times a day with their blood pressure. How often do you think they should be checking it when they're at home?
At least in the morning when they wake up and
It doesn't have to be daily, but they should be checking it at least monthly. At least monthly. Whether they're doing it at a doctor's office or checking it themselves or having, a nurse practitioner look at it or going to Walgreens and doing the pump up thing at Walgreens or Walmart. They need to be keeping an eye on it. Because if they start gaining weight, their blood pressure may be going up and they don't know. It's asymptomatic. So frequent blood pressure checks means at least once a month. Okay? Tell them, hey, once a month, go in there and check your blood pressure. Let your doctor know if it's going out of whack. Okay? They're the only ones that are going to be assessing it. And you can encourage them to do that. You're on a blood pressure med. Don't assume it's going to work forever. Your body will change. Things will change. Things may stop working. Things may work too well. Keep an eye on it. So it's asymptomatic. They're the only ones that can keep it. They need to go see their doctors. They need to check their blood pressure. Report any signs and symptoms to the medical provider. So especially if they weren't having it and now they're having it. Maybe their dose is too high. And they're having orthostatic hypertension. They can't, and they're not getting to their blood pressure, but they can say, I'm dizzy every time I get up. My mother-in-law did that. She was like, oh, I need a minute. And I'm like, why do you need a minute? She goes, they started me on a new med, and I'm just not doing well. I feel like I'm going to puke every time I stand up. And I'm like, well, what's your blood pressure? She's like, I don't know. Well, let's go take it. It was 90 over something when she would stand up. I'm like, that dose is too high. You need to go back to your doctor. They need to take care of themselves. And she was just like, oh, he put me on this med. I'm going to take it. And I'm like, but you're not doing well on it. Come on. You're going to pass out. You already had a stroke. Don't do this. And then if they take their meds, so don't take it when you get up in the morning because then it's going to drop your blood pressure out a little bit. So most of these meds should be taken probably at night when they can sleep it off. But just know they're going to might have some orthostatic in the morning. But you should always encourage your patients to check on their blood pressure and know that things can change and nobody's perfect and not all doses stay perfect forever. Keep an eye on yourself. All right, so diuretics. Here they are. Probably already seen them, right? Diuretics are for many, many different reasons. Why do we give them? Get rid of fluid. These first ones, the thiazide ones, are the most common for patients taking them at home and for blood pressure management. The thiazide diuretics are longer. They work the same as the loop diuretics, but loop diuretics are more potent than the thiazides. The thiazides will not let you retain sodium, so you pee out your sodium. What goes with it? Water. So you'll lose some water, but it also gets rid of other electrolytes, so you're going to have to watch them. And then it's basically less fluid retention, and it takes about 2 to 4 weeks to work to really get that full effect because they're not very potent. So this isn't the med that you give them and they're going to pee out 600 cc's afterwards. 600 liters. They're not going to pee out right away 3 hours after you give them. They're just going to notice that they maybe have to go to the bathroom a little bit more, but they will be getting rid of fluid. So thiazide diuretics are usually what we put long-term hypertensive patients on. Then if they need a little boost, or maybe the thiazides aren't getting rid of as much fluid as you need to, or maybe you're having more fluid retention and you need to take care of that, the loop diuretics are more potent, but they don't last as long. You might have to take them a couple of times a day, and you whoosh out a lot of urine right afterwards. They work in like an hour or two. They're not good for long-term management. They're good for short-term, I got to get rid of some fluid, and I got to get rid of it fast. Which is why you see people coming into the hospital and they get Lasix. Now, some people are on home Lasix, probably because the thiazide ones weren't getting off enough fluid. and so they go on home Lasix. But usually home Lasix is once or twice a day, because it's just not as effective. But as people have been in this situation for years or have other problems, they may ramp up. And then after, potassium-sparing diuretics are just another class. They are the same as loop diuretics in terms of the fact that they get rid of a lot of fluid. But what do you think they keep? Potassium. Hey, that's pretty good, because we don't want to lose our potassium. You'll find out next week why in fluid electrolytes. We don't really like losing potassium. These will spill out just all the electrolytes. This one will keep potassium. What do you think you got to monitor around that one?
Too high.
Yeah. So for all diuretics, so if you're on a diuretic, whether it's a loop, a thiazide, or potassium sparing, you have a potential for fluid and electrolyte imbalances. Okay? So they will need to get their labs drawn. You will need to monitor them in the hospital because they're on a diuretic. They're going to need to do this. Now, we told you daily weights from before, but now you really have to do daily weights because we are artificially drying you out. We got to make sure we're not going too far the other way or we're doing something effectively. We need to make sure we're doing our daily weights. They need to get their lab work done. This isn't like, once a year I'll get my labs done. No, we're spilling electrolytes. Got to make sure you're not getting too bad off. They can make you dizzy, headachy, and weak. Why? There's less fluid in your body. If there's less fluid in your body, there's less fluid pressure up to your head, and so you might get dizzy, headache, or weak. Why do you think they make you anorexic, nausea? Why do you have GI symptoms with diuretics?
All the water is being kind of diverted to the GI system.
Yeah, everything's being shifted. Now, the water's not really being diverted to the GI system. It's getting pushed out of the body. But that causes fluid shifting in the body, and the body's getting signals like, I'm not really sure what's going on right here. Let's not put more food into us right now. So it just kind of is like a little side effect of like, I'm not sure what's going on. The body's trying to figure out all the shifting that's going on, and so sometimes it comes across as GI effects. I don't know why it's photosensitivity and skin rash, but there is a risk for, so basically they're not supposed to, it's actually the med itself for Lasix has to be kept like in a dark container and stuff like that. That's very, it makes you also sensitive to light. And of course, the higher a dose, the higher the effect. And advise patients to supplement with potassium-rich foods is for all of them except the potassium sparing. Not potassium sparing. I can't write. This is a K. So yeah, I don't want you telling them potassium-rich foods if they're on potassium-sparing diuretic. But otherwise, all of them. Okay. And then there's a couple more. I actually have a diuretic med card that I will post for you guys so you can see how I do the med cards. But I did one for diuretics, just to do an example card. But specific to thiazide diuretics. So which ones were the thiazides? The long-term ones, usually the first round choices. Hey, but they can have cardiotoxicity of digoxin. Okay, so if they're on digoxin and a thiazide diuretic, your little radar needs to go up. Okay, just kind of put that aside somewhere and make a note of it. That if you're going through a MAR and your patient's on digoxin and a thiazide diuretic, you need to pay attention to your K. It's just something, a little tidbit that you do have to put aside. And a patient, you'll find out when we do block 4 digoxin is for heart failure. So we have a lot of patients who are on diuretics for hypertension and they have heart failure. Goes together a lot, so we have to keep that little earbug out. So I'll repeat that to you in block 4. Non-steroidal anti-inflammatories, they kind of affect the kidney, non-steroidals, and can make you pee a little bit more. So just something that they may need to work out, pay attention to. Loop diuretics, if you give it too fast, you can make them deaf. It is ototoxic. Why? I have no earthly idea. But if you push Lasix too fast, it can cause hearing loss. Very, very long-term use on high doses can cause hearing loss as well. It is an ototoxic drug. So there's that. That's just a little tidbit. Fluid and electrolyte imbalance. Just monitor your fluid and electrolytes. I don't need you to memorize which ones. Just get your labs. I'll give you labs if I'm putting you on a diuretic and I want you to worry about your labs. Loop diuretics also work even when your kidneys are bad. So sometimes if a patient's got kidney failure and hypertension, you may see them on Lasix as their drug of choice rather than thiazide diuretics. And potassium-sparing diuretics. Hey, you get too much K. This one's not that common, and of course, would you be on this is working in the nerve system. It's not that common. I've seen it a couple of times, but would you be on one of these and a beta blocker? An alpha blocker and a beta blocker? No. It's in the same system. So maybe patients can't take a beta blocker, but they can take an alpha blocker. That will hit that sympathetic system. Okay. Alpha blockers, where are they going to work? Where? Yeah, on the vessels. They're going to work on the vessels and block vasoconstriction of the vessels, so they produce vasodilation. Don't worry about SVR and BP. I pulled some of this slide from don't worry about SVR. They just decrease the vasodilation and decrease BP. I pulled some of these slides from a class that I used to teach. I used to teach the telemetry to ICU class. And so I pulled some of these slides from that, and I'm like, oh, you don't know. You don't need to know about SVR. That's an ICU word. So reduces sympathetic stimulation from the central nervous system, meaning it just blocks those alpha receptors in your vessel, produces vasodilation and blood pressure. So because it has some central nerve effects, these are very common with alpha agonists: dry mouth, sedation, erectile dysfunction. A lot of these drugs cause erectile dysfunction because that works on a pressure system. You need pressure to have one, and so what are we doing to these poor people? We're dropping their pressure. So some erectile dysfunction is a very common side effect that a lot of people don't like. Why would it have symptomatic bradycardia? What does that mean? It doesn't work in the heart. It works on the vessels. So this one may drop your blood pressure. When you have a vessel that's tight, what's the heart doing? It's trying to get blood in there. And then you dilate it. It's like, whoa, whoa. I can slow down. It's just like a reflex thing of basically reducing the pressure that it's pumping against. It's like, oh, that feels nice. I'm gonna slow down a minute. So symptomatic bradycardia. So it does affect your heart rate, not directly. Doesn't affect the receptors, but you can have a decreased heart rate with it. And the one big thing with it, if I could have you pick anything, the most common ones are here. The biggest one is this withdrawal syndrome with it. They can't stop taking it. They can get rebound hypertension really fast, tachycardic. They basically reset quickly. It's like you were telling it, don't constrict, and you stop taking this med, and it's like, constrict, and it massively constricts. So this one has a big withdrawal syndrome, rebound, which is severe hypertension and tachycardia.
So if this medication starts to not work, do you just lower the dose and add it?
Yeah,
add another,
yes,
add
they
another
will taper this one off. This one isn't something you can just stop and restart another one. So if you're on clonidine, it's an alpha agonist. It's really it's the only one in this class. They don't really like to use it. They'd rather use a beta blocker, but some people can't tolerate beta blockers. Maybe their heart's affected, and they'll go with one of these instead. But again, you're not going to be on a beta blocker and an alpha blocker. They work in the same system. Oh, what is that? Oh, wait a minute. This is an alpha adrenergic. Okay. Alpha adrenergic agonist. I have to think about alpha antagonists. I can't remember the difference between what they do. Alpha antagonists, they're basically in alpha blockers, basically the same kind of thing. They're working on those vessels. I'm trying to remember antagonists and how it's working. I don't remember. They both cause vasodilation. This is just a different class. So again, you aren't going to be on an alpha blocker and alpha. That's why clonidine's an alpha agonist. know how to explain that to you. I'll have to sit down and think about that. Maybe after lunch I can sit down and process how to explain the difference between alpha agonists and alpha blockers. But this is the same thing, that they will block vasoconstriction, and these are sins, right? Most of those are sins. The ends of these. So if you see a drug that has sin at the end, it's probably in the alpha blocker category. This Regitine happens to work that way, but it's not a true alpha blocker. Just it's in that category, but it's not 100% an alpha blocker. Otherwise, it would have had a sin end of the name. But sins are alpha blockers. And with alpha blockers, just know it's a sympathetic thing. It's going to cause cardiac issues as well because we are causing vasodilation. It's going to cause vasodilation. This one works, these work fast. So you'll see within 90 minutes. But I'm going to have you, with all your blood pressure meds, check them within 90 minutes. They all work that quick in at least an hour or two. And most of your blood pressure meds, if you look them up, they're going to peak in about an hour or two. I'm going to want you to recheck them in an hour or two to make sure they're not too low. Every single one, you're going to be checking your blood pressure. So the sins are alpha blockers. I'm going to get you a better answer on the alpha adrenergic if you want the background behind it. Otherwise, you can just remember that they're alphas. Here are your beta blockers. Same family, sympathetic system. So if you're on a sin, you probably won't be on an olol, because you're not going to do alpha and beta probably. They're the same system. Cardioselective beta blockers, non-selective beta blockers, mixed alpha and beta blockers. What do they all have as their end? They're all olols. So olols are beta blockers. I don't need you to know the difference between the three. I just need you to know that olols are beta blockers. If a patient is having heart issues, they may not put them on a cardiac one, the one that works in the cardiac ones primarily. These ones will work beta 1 only, so these only work in the heart. So they'll decide, the doc decides. This is why you're not deciding which ones to give them. You're just telling them you're on a beta blocker. These ones will work in the heart and the lungs. So what are you going to have problem with this one? You are blocking. So what are we blocking? What do betas stimulate? Heartbeat, heart rate. So when you are stimulated, then you have an increased heart rate, increased contractility, and what happens to your lungs? They dilate. They open up to allow more oxygen in. So if you block that, what's going to happen?
Constrictions.
Your heart is going to slow down, your heart's not going to pump as strong, and your lungs are not going to open up as strong. So is this a good med for people who have asthma? No. It works in the lung vasculature, not great for people with asthma. I think that's on the next slide. Mixed alpha and beta blockers will work on the vessels and the heart and the lungs. And so, again, I just need you to know that they're beta blockers, that they have heart effects. Okay. And here's what I want you to really know about these. Beta blockers may cause bronchospasm, especially in patients with asthma, so monitor for wheezing. Now someone would be like, well, a cardioselective one won't because it doesn't work in the lungs. You're right, but do you want to memorize all of them separately? What would it hurt you to monitor them for wheezing if they're on a beta blocker? If you got the wrong one, you just listen to their lungs. It's okay. You're all right. You know that beta blockers, most of them affect the lungs as well and can cause bronchospasm. Monitoring EKG for bradycardia because they do affect the heart and slow down the heart. They will cause bradycardia. Monitor for impaired peripheral circulation. Why? What's happening here? What are we doing? You're slowing down the heart and decreasing the strength at which it's pumping. So what's that going to decrease? Your perfusion. So we want to make sure that they have good pulses, good cap refill, good circulation in the extremities. Again, nightmares, depression. I think this has to do with the fact that there's not as much blood flow up to the brain very well. Erectile dysfunction is a common side effect of these. It can exacerbate heart failure. What are we doing? We're slowing down the heart and telling it not to pump as strong. If it's already got heart failure, not the best drugs. So anyway, this one also has a withdrawal. So we're kind of seeing a thing that some of those alpha betas, don't withdraw them. They cause problems when you are blocking something and then you allow signals back to it. So don't withdraw them. Calcium channel blockers are in their own thing. These will cause smooth muscle relaxation. Here, now I'm using fancy words. So we're trying to get you to learn a language, and you're not in medicine 3-4 yet. You're only in medicine 1-2. So a lot of these words are medicine 3-4 words. So I'm going to get rid of the ones that say decrease SVR and R2. It just decreases your blood pressure, resulting in decreased blood pressure. It will decrease your heart rate because calcium is also a conductor around your heart as well. So these will affect your heart rate as well, not because it's stimulating your heart, but just because it's kind of slowing down smooth muscle relaxation, and it also slows down your heart muscle. So things kind of slow down. It also slows down conduction through the heart, the electricity getting through the heart. So we need calcium in a lot of different places. But one of them is muscles. You need calcium to relax your muscles. You'll see this when we do calcium. But if we are blocking calcium, muscles can't contract, basically. Smooth muscle can't contract. So if you are blocking calcium, they results in vessel relaxation. It can't contract. We've blocked the calcium from crossing channels, and it can't make that contraction happen. So calcium channel blockers cause vasodilation. Don't give them to patients with heart failure or heart block because it's going to slow your heart rate conduction down. You've already got problems. Probably not the best choice. So if your patient develops heart failure, heart block, and you see him on a calcium channel blocker, you might want to double check. This is the only one that doesn't have like a nice ending word. Like it doesn't have... You're like, there's an M and an een and a mill and an een. Eens and mills. This one you probably, if they don't fit into the other categories, it's probably a calcium channel blocker. The most common ones, though, are the eens and the mills, the nicardipine, verapamil, nifedipine, amlodipine. So they kind of sound like eens and pearls. I don't know if it has to do with where they work. But we'll call these eens and mills. If they're eens and mills, they're calcium channel blockers. And then there's just diltiazem. You're just going to have to, I don't know why they named it that, but they did. Like, why can't you just make it easy for us? Eens and mills, calcium channel blockers. But they're pretty well tolerated by people. These do their job. They're just not good for cardiac patients, but otherwise... they're pretty good meds, so a lot of people are on calcium channel blockers. It can affect your heart rate from that reflex bradycardia. But this one is a tidbit that's everywhere. Don't take them with grapefruit juice. I don't know why. Don't take them with grapefruit juice. Just don't give people grapefruit juice if they're on meds. It interacts with everything.
A lot of people drink grapefruit juice.
I don't know. I don't drink grapefruit juice. Okay. Eens and mills, calcium channel blockers. ACE inhibitors. What are these? What's their last name? These are prills. Oops, go back. ACE inhibitors are prills. So if you see prills, they're an ACE inhibitor. They are going to work up there in that renin-angiotensin system, and they have something to do with something secreted by the lungs. So I always like to remember ACE inhibitors, that this angiotensin converting enzyme, which is the short for ACE, comes from the lungs. So when you do these ACE inhibitors, they affect the lungs. I just try to remember ACE inhibitors in lungs, prills in lungs, however you want to get that in your head. But they are basically blocking the angiotensin the renin-angiotensin system, and they're doing it at this thing that's secreted by the lungs. So they have a dry, hacking cough. It affects their lungs, and because it's blocking that whole end system, what's it going to do? What's it blocking at the very end? That angiotensin 2, what does it do? It vasoconstricts, so we're not going to have vasoconstriction. So if we block it early in the cycle, we don't end up with the vasoconstriction. But what also don't we have at the very end of that cycle? What was holding on? The aldosterone. We don't get the aldosterone either, so we don't have fluid retention and sodium retention. So these ACE inhibitors block that whole system from happening. So you don't get vasoconstriction and you don't get fluid retention and sodium retention. That sounds great, right? Until you need your sodium and water retention and you can't have it. So it works down there. It gives you a dry hacking cough, but you can have issues with not being able to hold on to water. So what do you think they work like? They're kind of like diuretics. ACE inhibitors work down here in this system involving the kidneys. It's a kidney blood pressure med, and they may have problems retaining water. So they may pee more often. And if you put a diuretic on top of an ACE inhibitor, they really are going to lose water. Just things to think about. If you know what system they work on, if you remember, ACE inhibitors work in that kidney system, but they also have that lung component that gives you the cough.
I have a random question. Can you
Yes.
drink alcohol when you're on any form of blood
You
pressure
should
med?
not drink alcohol on any blood pressure med.
Okay.
Good question. Why? What did we talk about alcohol being a risk factor? Well, one, it's a vasodilator directly. So we're already taking blood pressure meds, and you're going to give a vasodilator. The other thing is it's going to go down there and affect your kidney and mess with your kidney and that renin-angiotensin system, especially if you're on meds to mess with that system already, and then we're going to go down there and mess with it. So, no alcohol on any meds. ARBs, there isn't a single one. If you get it, I know, sorry, buddies. And that's why a lot of people on these meds will drink alcohol and pass out more because they dilate themselves out.
So would doctors most likely not put someone who's on this on a diuretic also?
They may have to, it depends, but just know that if they're on an ACE inhibitor and a diuretic, their chances of being orthostatic or losing a lot of volume are pretty high. And that might be what they want.
Yeah.
Maybe they're putting them on a diuretic because they have so much fluid overload that they need double whammy to get that fluid off of them. So it does work down there. ARBs are the same thing. They work down in the renin-angiotensin system. They work down in the kidneys. What are the last ones for these? These are TANs. They're TANs. So we have prils and TANs. The TANs are only there to block the angiotensin 2. They prevent the angiotensin 2. So they actually block at the very end. Okay, they don't block just angiotensin. They block the whole angiotensin 2 and aldosterone. So they work at the end of the cycle too. They're just like the ACE inhibitors. They just work at a different spot in that cycle, but they block the end of the cycle. So they're going to have the same effects as the ACE inhibitors, but without the cough. So sometimes they move people to these. But they will also cause fluid and electrolyte. Their issues with their sodium and water retention takes a while for them to work, and they're great for people that develop the cough. And why they don't start people on them, I don't know. But they do put them on them. They could be anywhere. But are they going to be on an ARB and an ACE? No, they do the same thing. Why would you put them on the same med twice? So no, they aren't usually on an ARB and an ACE. They're usually taken off of the ACE and put on the ARB, or taken off the ARB and put on the ACE. They do the same thing. And last one, aldosterone receptor blockers. These only block aldosterone, so they're not that great because they're still letting that angiotensin vasoconstrict. So they're not 100% working, but what do you think they are? They're going to block aldosterone. What are they going to get rid of? Fluids. They're going to get rid of fluids and sodium. When you get rid of fluids and sodium, you keep potassium. So what are they? They're potassium-sparing diuretics. So aldosterone receptor blockers are also known as potassium-sparing diuretics. Even though they're classified under antihypertensive and they work in the renin-angiotensin-aldosterone system, they actually act as diuretics. So you may see them being used as diuretics because they're not really preventing any vasoconstriction. They're just preventing the water reuptake and the sodium reuptake. So they are potassium-sparing diuretics. You may see them in either spot. You may see them as potassium-sparing diuretics. You may see them as antihypertensives. But do they get used with ACE inhibitors or angiotensin II receptor blockers?
No.
They're in the same class. So you shouldn't put meds together from that same system. So make a table. Figure out the best way you want to do it. I will post the diuretic one that I made for med cards. I would suggest, and your future self will thank you, that you have these already made when I'm like, hey, when we're in the renal section, pull out those diuretic cards. And you're like, I burned them. Don't burn them. So I think this is almost the end of, this, and then we'll go to lunch. So hypertensive crisis just means that your blood pressure is super high, danger high level. Danger high level, there are two different kinds. One happens quickly, one happens slowly. So your blood pressure is climbing to a danger high level. What is a danger high level? What was the top limit of the stage 2 hypertension? Can someone go back to that side? Huh? So the top level was greater than 180, right? So one's greater than 160? And what's the highest diastolic? Greater than 100?
Yeah.
Okay. Well, I'm going to have to look in your book to double check, because you guys all have the 10th edition book, right? I want to look and make sure how they classify these in your book. Does anybody have their book
I
with
do,
them?
yeah, hold on. Stage 2 hypertension, greater than
No,
160.
no, I just want to double check for hypertensive urgency and emergency. Are those the same?
I don't have that, sorry.
I got it out of the book. It was, they said the price of the first systolic greater than 180 or diastolic greater than 110, and
So greater than 180, diastolic greater than 1. So that's right. That's correct with the urgency. And then does it say something for hypertensive emergency?
I couldn't find anything.
Okay.
But it said-
Then I can make it up.
It just said the difference of the organ DNA.
Okay, so this one is our basically where we start to alarm bells going off. If your blood pressure is systolically greater than 180, diastolically greater than 110, alarm bells need to go off in your head that this is an emergency. Okay? This is urgent, this is an emergency. This is not something that can wait and let's play around with some meds and let's do a couple things. This is an emergency. Because what's happening at greater than 180 or greater than whichever number it is, the worst number classifies you. So if it's 190 over 100, I'm still calling it urgency, emergency. Okay? We'll just put them together, urgency/emergency. Don't worry about this one. So here, let me fix this one too. We are going to not worry about this. I just want you to worry, because I know you guys get mired in details. And I don't want you to make this one of your sticking points. I want your warning bells to go off greater than 180, greater than 110, whichever one is worse. You need to stop what you're doing and treat this patient, okay? At this high of a pressure, your kidneys are going to get damaged. What's going to happen? What's your risk in your head? Of stroke, of blowing a blood vessel, not clotting a blood vessel, but actually physically blowing a blood vessel in your brain, causing a hemorrhagic stroke. So we start to really perk up our ears and, okay, now we have to get some IV medicines. We've got to do something. This isn't a wait, let me call the doctor in a little while. This is now an emergency. Yeah, so this is where we start trying IV things. We start trying we're really on the ball to get this down. Because the target, okay, let me fix this slide some more. I realize this says things that I don't even care. 180 over 110, risk of stroke, renal failure. This is really what we're worried about. Let me just sum it up. That this, and I will upload these new slides at the end of this lecture, so I'll put corrected slides. I'll leave the old slides, but put corrected slides on there. So blood pressure greater than 180, you have a risk of stroke or renal failure, and we need to get this blood pressure down. So this is something that you need to go ahead and call for and figure it out. This is the causes that you're going to have: neurologic, bleed. They may have headaches, seizures. This is something that maybe they come in with a terrible, horrible headache, and you take their blood pressure, and it's 200 over 190, and you're like, oh. They can go into massive acute renal failure because these vessels are completely constricted to the kidneys and there's no blood flow to the kidneys. They can end up in cardiac failure. Can you imagine the heart trying to pump up against this? That's too hard for the heart to pump against. It will fail too. You can also blow your aorta. That's a high pressure. We have to get it down. So I want your alarm bells. So there's pre-hypertension. Oh, do some lifestyle changes. There's stage 1, there's stage 2, some lifestyle changes, maybe some meds coming in there, maybe 1 med, maybe 2 meds, maybe 3 meds, maybe 4 meds. Hypertensive emergency, that's not med adjustment, that's you're in the hospital and we are actively trying to get your meds down, okay? And this is where they go into the hospitalization, frequent blood pressure checks, heart rate, neuro checks. You are making sure you're very close to a pressure boiling point, basically, in your body, and it needs to come down. Do not spend your time on these, okay? They are there. You will see them again, maybe listed in block 4 or whatever. Direct vasodilators are IV use for severe hypertensive emergency. Are they going to be on the floor? No. They're going to be in the ICU, so you're not really going to see them unless you're in a critical care. I will bring them back for block 4. So do not put these on your I have to know for the test list, but you may see them in clinical, and I would want you to, how many people have seen hydralazine? It is a calcium channel blocker. It's an IV calcium channel blocker, and it brings down blood pressure fast because it's an IV calcium channel blocker, and it causes direct vasodilation. Brings down blood pressure fast. Nipride is a direct vasodilator. Nitroglycerin is a direct vasodilator. So they bring down blood pressure fast in their IV forms. You may see them. I want you to at least have said, oh, that's what we're doing for that. So you're not going to give them a bunch of pills. You're going to start going to IV stuff when they're hypertensive emergency. So that's where the direct vasodilators go. So let's go to lunch. And I will let you digest hypertension.